Welcome to today's program, and thank you for joining us. I'm C. Virginia Fields, former Manhattan Borough President, and currently the President and CEO of the National Black Leadership Commission on AIDS, Inc. The mission of the National Black Leadership Commission on AIDS is to educate, mobilize, and empower black leaders to meet the challenge of fighting HIV/AIDS and other health disparities in their local communities. On June 29, 2014, Governor Cuomo announced a three-point plan to end the AIDS epidemic in New York State. And the plan's stated goals are to, 1, identify persons with HIV who remain undiagnosed and link them to health care. 2, link and retain persons diagnosed with HIV to health care and get them on anti-therapy. And 3, facilitate access to pre-exposure prophylaxis, better known as PrEP, for high-risk persons to keep them HIV negative. On today's program, we will discuss the governor's blueprint to end AIDS by 2020 and its impact on the state, the nation, and especially communities of African descent. But before we do that, let me just share a few facts with you about HIV in New York State and United States. New York State is among the 5 leading states that account for the majority of HIV cases. There are an estimated 120,000 people living with AIDS in New York as of June 2014, with 45% of them being of black descent. CDC estimates show that blacks account for almost half of all new infections in the United States each year, 44%, as well as more than 1/3 of all people living with HIV, 41%. And approximately 1 in 16 black men will be diagnosed with HIV during their lifetime, as well as 1 in 32 black women. So here today to discuss this topic of ending the epidemic task force member, Ms. Terry Hamilton. Terry Hamilton is the Assistant Vice President for Corporate Planning Services in the healthcare system of New York City, as well as Director of HIV Services at the New York Health Hospitals Corporation. In this position, she is directly responsible for strategically managing and setting policy for the HIV-related activities of 11 acute care hospitals, each a New York State Department of Health certified designated AIDS centers, and 6 diagnostic and treatment centers. This program that she manages is the second largest to the Veterans Administration and provides HIV care to 19,000 persons living with HIV/AIDS. Terry, thank you so much for joining me today. I mean, just reading that bio and thinking about all of what you do, I'm like, how do you get anything else done? I mean, that's major. So why don't you tell us a little bit, Terry, about your background and kind of what led you to do the work that you're currently doing in the field of HIV. And again, welcome. I'm really glad to have you.
Virginia, I'm delighted to be here this afternoon and talk with you about HIV and AIDS in the New York City community. I actually started my activism a long time ago working in civil rights. I'm an old CORE member working with Long Island CORE and their Black Leadership Development Program. And after college, I began to work with high school dropouts and eventually worked at Harlem Hospital in the Department of Psychiatry. And finally, I walked into East Harlem's Settlement Health and Medical Services, interested in a smoking cessation program, and they said the job was taken. But they had a little program that was very important. It was a program around education on HIV and AIDS. And they said, would I be interested in doing that? And I was. The reason I was because I actually had a very dear friend that I attended church with for many years who died of HIV and AIDS. And I'm not a physician, I'm not a nurse, but I felt I could do one thing really, really well, and that was care about people in my community. I've lived in Harlem since 1980 and do well by them in terms of a healthcare program. And so that really started my commitment, having this experience with a very dear friend, knowing that it was at a time when people were afraid to touch people with HIV and AIDS. And that made me very, very sorry for myself and for how my friends were being cared for. And I wanted to do something about that in East Harlem. And I was able to.
That is so interesting because for as long as I've known you, I didn't realize how much of our backgrounds that we share. I too come out of the civil rights movement, having been born and grew up in Birmingham, Alabama, and having my views on a lot of what I continue to do as a social worker and as an elected official, having been shaped through those earlier experiences, wanting to make a difference, wanting to use your own background to improve lives of others as well as to have yourself improved. And then, of course, moving into the field of HIV. After elected office in '06, I just wasn't sure what I wanted to do. Not really, but I knew I wanted to go back to do something in my field as a social worker after having got, my master's in social work from Indiana University. So I was introduced to HIV/AIDS in a way that I had not experienced even as an elected official, having supported budgets, having supported legislation, having friends who had also died from HIV, colleagues, co-workers, but I did not know the impact of HIV in Black community, especially Black women, until the founder of the National Black Leadership Commission on AIDS, Deborah Fraser House, whom we both know, approached me, and my first reaction was, no, I don't want to do that. I don't know anything about AIDS. That's too much work. I don't want to do this. After I started reading more and understanding it differently than the work that I had done, I was hooked because I could not imagine, why don't we see more education in the Black community? Why aren't African Americans and Latinos the populations most impacted by HIV? No more. And that's our common experience. So I'm glad to hear about that, Terry. I didn't know all of that, but and interesting, I thought you were in the medical field.
No.
And most people think you are, right?
Right, they do. And sometimes I even get called doctor. But the other thing that was instrumental in my doing this work was actually my mom's work. My mom worked in Orange County in New York State, and she worked under the old Office of Economic Opportunity. And the focus of the work that she did was rural poverty. So I really knew something about the connection between healthcare and access to healthcare and poverty many, many years ago from the work that my mother did. And then after graduate school, I came to live here in New York City, worked at Columbia in the Double Discovery Program, which you're probably familiar with, and went on from there to eventually work here in East Harlem. In fact, across the street from this very studio, in a building that Hope Community helped to renovate. And that's where we've had our first large HIV program here in East Harlem.
Wow, and you have continued to be very, very successful in your work, and I'm just so delighted for what you're doing in the field of AIDS. Now, I know that you were appointed to the Governor's Task Force, as I was back in October of last year, to really do work about the goals that he laid out in this plan. So why don't you talk a little bit about the work that we did as members of the task force and the area that you were assigned, because I think we we're not in the same group. And then we'll talk a little bit more about specific recommendations or things that we think might need to happen in order to actualize the goals that have been established with respect to the recommendations that have been established with respect to the goals of the plan.
Well, working at the New York City Health and Hospitals Corporation, one of the very first things that we were interested in was using quality improvement methods to help improve the delivery of services to our patients. And so I've been a longtime member of the State Quality of Care Committee, and I think it was out of that work that I've done with the state that I was invited as a representative of HHC to participate in the governor's task force. I was on the care committee looking at what are the kinds of things that we need to do to dramatically decrease the new incidence of HIV infection. So really what we're talking about is that phrase called bending the curve. And you know, if we look back a couple of years ago, around 1990 or so, maybe there were 15,000 new infections each year. Well, we want to drive the number of new infections by 2020 down to less than 750 a year. And part of the care committee's job was to figure out how do you do that? And certainly the prevention committee, which was another committee, will be looking at things, and they particularly looked at PrEP, which we may get a chance to talk about.
And that was my committee also that I
Okay.
worked on prevention.
But the care committee looked at what are the things within the care realm that we could do. So one of the hidden things that we really focused on was making sure that the care was culturally competent. And what do we mean by that? If we're African American, it means when we go to a provider, when we go to a clinic, is that a clinic aware that there are many diverse communities of African descendant people in New York City? That you deal maybe with the needs of African American women differently than you would deal with the needs of Chinese American women. But we also mean by that when there are communities of people who are transgender persons, lesbians, gay men, men who have sex with men, that also the services are open to them, they're sensitive to the needs of those communities to feel included, not stigmatized for particular behaviors that they have, any more than we would stigmatize somebody because they have an accent or somebody because they're using drugs. We want to get people access to health care. You have to have access in order to be able to drive down the new incidences of HIV and AIDS.
Now, given the fact that the people on each one of these committees, even though the majority seemingly of persons participating on the task force are from New York City, we still had people from, you know, upstate and other. Did you find any points of difference in terms of how we tend to approach these issues from New York in comparison to some of the people coming from upstate?
Actually, we did not. On the care
That was
committee,
good.
there was a great deal of unanimity. We were all concerned about driving people's viral loads as low as possible by making sure that they are in regular care, that they're linked to care as soon as possible. But there are some areas where there are unique differences in different parts of the state. Transportation seems to be a larger issue in rural areas. But on the other side, when you look at correctional institutions, there are jails here in New York City, there are prisons in upstate New York, and many of us are concerned about the kind of access to care and treatment that are in prisons as well as in jails, for example.
I know another big issue that I think continue to come up, the fact that here in New York State we have mandatory testing. And if more people would get tested or tested, then hopefully we will be able to reach more individuals who are diagnosed as being positive. What is happening with mandatory testing as it relates to this blueprint and being successful in those areas?
Well, I actually want to clarify that, because that is actually a point that many people are a little bit confused about. The regulation in New York State is about the mandatory offer of an HIV test. We have preserved for the New York State community the right to refuse a test if they so desire. Actually, our goal in healthcare is to encourage every New York City resident, every New York State resident who is 13 years of age, and I believe older, even older than the CDC recommendation of 64, to get an HIV test, to know their serostatus.
Why is it 64?
Well,
People assume
because
people
in the-
after 64 do not have sex?
Exactly. Or they do not have certain drug-using behaviors. And actually what the information from groups like ACREA here in New York City show is that people who are over 60, over 64 are sexually active. They have very complete lives, including lives that put them at risk for HIV. And we as healthcare providers, as people who are interested in both prevention and care, have to accept that and make sure people feel comfortable about telling us about the behaviors that they engage in. So just to get back to your original point, it's the mandatory offer of a routine test for HIV. And what that means typically is when you come to your doctor for a primary care visit, when you come to your doctor for a flu shot, when you come to your doctor, maybe the dentist, they're going to ask you, Virginia, would you like an HIV test? And they're going to make it quick for you. You're going to get the results very, very quickly. It's a painless test. And what it does for you is kind of give you a baseline. It says where you are today. And it allows a conversation to take place in the clinic, in the doctor's office, to say, Virginia, today this is where you're at. These are the kinds of things that you might think about to preserve your health and the health of the people that you care about.
Do we have any sense of how successful we are with respect to doctors offering the test? By the way, I heard recently that they're looking at the oral dental test also for hepatitis C because of the increase in numbers of persons who are being found to have acute chronic hepatitis. So the discussion is very similar, having dentists do testing for hepatitis C. But back to the point of the routine offering a routine test to persons, and are we seeing an increase in the number? Because it would seem to me that would be very important to the first goal in the blueprint, and that is getting people tested to make a diagnosis, and of course, if tested positive, getting them linked into care. So what are we seeing on the front about mandatory offerings?
Okay, well, I can actually brag a little bit about the work that we're doing at the New York City Health and Hospitals Corporation. In 2006, before the CDC recommendation about routine screening, we made a commitment at HHC to do routine screening. And between 2006 and 2014, how many people have we routinely screened for HIV? Over 1,555,000.
Between 2006 and 2014,
over 1,555,000 unique patients. And 5,000 plus were new diagnoses.
Wow.
We actually have the largest HIV screening program in the United States, right here in New York City at HHC. And we've done another thing that I think is really important that sort of goes underreported. So not only did we do this large volume screening, but we actually have a research project that looked at how do you make screening more routine. So when we thought, as we started, it was just the volume of screening, we kept track of the numbers of patients that we screened. And working with epidemiologists, we looked at what happened over a 7-year period. And we actually have a recommendation that was so important. It was published as an abstract in The Lancet, the British Journal of Medicine. And that recommendation is that routine screening in a large volume setting like HHC takes place when you screen between 20 and 40% of the age-eligible patients. So that's very, very important because it helps planners in healthcare institutions know what to do with the limited resources that they have. So we have the largest HIV screening program right here in New York City, but we also have this very important suggestion about how to refine routine screening.
And that's a part of the recommendations coming that we're seeing in the blueprint. Now that's going to be very important for the first pillar, if you will, of the blueprint in terms of getting people tested and screened, and the work of over 1.5 million.
1.555.
1.555 million that at least we are well positioned here in New York City. So now once we've gotten people tested, the next step is getting them linked to care and keeping them in care, because I think when we look at the data of those who are coming into care and we look at the end results of those who remain in care, to have the viral load suppressed, which means that they are not transmitting the virus onto others, there is a real decrease. So how do we get linked into care, keeping them in care, so that the viral load is suppressed in terms of
So what you're really talking
treatment?
about is the national Cascade, and then the Cascade in New York State and in New York City. And what that does is really look at screening, the disconnect between the volume that you're screening and how many patients are actually linked to care, and then how many of those patients actually have their viral load suppressed. So again, in some of the work that we're doing in HHC, we have some data on that. And so for the last 2 years, we have tracked our linkage to care rate, and 73% of our patients are linked to care within 30 days. And why that's very important was because when we looked at the data carefully, we found that there was a drop-off after 30 days. Fewer patients are actually actively linked to care, and being linked to care quickly is important because the longer you're linked to care, the better your health outcomes are. So in HHC, we really want people linked to care within the first 30 days of knowing their diagnosis. I wanted to talk for a minute, though, Virginia. You mentioned a couple of minutes ago hepatitis C. And actually, as part of the care committee, we were very concerned about hepatitis C because it's a co-occurring condition, often with HIV. And so we want to make sure in the clinics and hospitals, in the provider offices in New York City and around New York State, that just as important as focusing on HIV testing, we want to make sure that the older age cohort that is recommended by New York State to be tested once in a lifetime for hepatitis C actually does get tested. And there's a rapid test that does that work very quickly for patients.
And what are some of the reasons in your work, again, that you're seeing so many African Americans? I think it's like, well, not just African Americans, but 25% of the population perhaps who are positive for HIV and don't know it because they're not being tested. So in the case of African Americans especially, in your work, what are some of the many reasons you're seeing why we're not being tested?
Well, I think one of the reasons is people still don't always have the information. It's shows like this, it's a conversation with people, not pointing a finger at you haven't done this, you haven't done that, but asking you, what can you do today to help your health today? And it's also, frankly, that often African American women are taking care of other people in their families, however they identify those families. Sometimes it's blood relatives, sometimes it's neighbors and friends, but they're taking care of those people, and they use up so much of their time and energy taking care of somebody else that they often forget to take care of themselves. And then also, frankly, coming from a healthcare institution like HHC, we're very, very concerned that there are still many people who lack health insurance coverage.
Even with the Affordable Care Act?
Even with the Affordable Care Act. Now, at a place like HHC, we never turn anybody away, and we have many different opportunities for people to be covered, and we encourage every New Yorker to actually come to our facilities and seek the health care that they need. But part of the struggle is to make sure that people actually know how they can be covered under the Affordable Care Act. And HHC has worked with community organizations to do just that. Even in the work that I do in a discrete unit of HHC, we partner with community-based organizations to make sure that we're including information about healthcare coverage and access at our facilities, but frankly at other facilities if somebody wants to go someplace else. The bottom line is really getting people access to care. That's the first step in really driving down this epidemic.
And I'm so glad you mentioned about the role of HHC, the fact that no one can be turned away from care, whether they have insurance or ability to pay or any of the other reasons. And I have always been a strong supporter, certainly as an elected official, of HHC facilities for that reason, among others. Because when you, prior to, of course, affordable care, to see people not be able to access care because they didn't have insurance or they didn't have the ability to pay and denied health care was very, very troubling. So the fact that HAC is mandated whether you can pay, whether you have insurance, and we still need to get that message out there to people that they can come to an HHC facility, and the services have been enhanced and second to none in many of the HHC facilities. So I am a big supporter of HHC and have always been of HHC. So now we talked about getting people tested. We've talked about the wonderful ways that that is happening, certainly here in New York City, and hopefully through some of the lessons learned and the experiences here can help counties and areas outside of New York City. We've talked about getting people access to care and what's available. Now the third pillar is that of prevention, and that's this thing that we talk about called PrEP. And a lot of people are afraid because, again, of the lack of information. And here in the state of New York, since we're talking New York State plan to end, we know that black men who have sex with men are still among the highest among those populations who are affected, but also the population least likely to be using PrEP. So what can you tell us about PrEP? What it is, what it intends to do, and how can we get more of the population at risk on PrEP?
Well, Virginia, I want to step back for just
maybe not on PrEP. Let me take that back, because that's a personal decision that one clearly has to make, hopefully being informed by their own doctor whether or not it is right for them one way or the other. So I'm not suggesting everybody needs to be on PrEP, but I think having the information and being knowledgeable about what PrEP is, pre-exposure prophylaxis, I think is important.
And that will increase people's opportunity for access to PrEP. But I did want to step back for a moment and just frame this for us. So When we at HHC talk about prevention and we're talking about PrEP, we're talking about men, but we're also talking about women. And I want to make sure that everybody in our audience today is hearing that message. In a particular way, especially young African American men who have sex with men, African American women, both of those groups are underinformed about the opportunities for using PrEP. PrEP is simply a preventative measure. It's the medicine that you take to prevent HIV. And part of the way that you access PrEP is to go to any healthcare institution, the doctor's office, the medical clinic, the hospital, and say you're interested in PrEP. At HHC facilities, we have PrEP available to patients. If you don't want to go to an HHC facility, you can access through the Department of Health and Mental Hygiene, but there are many other organizations, clinics in New York City.
But how do we even get the persons to know that they should go and ask for PrEP?
So there are a couple of things that are happening. With the help of the Department of Health and Mental Hygiene, we are doing educational sessions for patients around PrEP with community-based organizations. Ciccatelli Associates, which is another group here in New York City that does a lot of education around health prevention, is also doing education around PrEP. And each of us as organizations who are involved in the commitment to ending the epidemic are trying to take on a slice of that pie of education to help patients know more about PrEP. And I want to make two important points. There are health insurance coverage for PrEP, but also the manufacturers of the medications, the drugs, have special programs for people who don't have health insurance, can't acquire health insurance, where PrEP is available to them as well.
Because it's rather expensive, right?
It is extremely.
Has it come down any in terms of the cost for the medication?
It has come down a little bit, but
what
really,
is it now, do you?
It is still a very expensive medication to take. And the other commitment is it's sometimes a very long-term medication. So PrEP is really focused on your risk for transmitting the virus. So there are two ways usually you take something like PrEP. One is called PEP, and that is post-exposure prophylaxis. You had an encounter, practiced unsafer behavior, and you go to the physician gives you a short-term treatment. These are the medications to prevent the transmission of HIV. PrEP, on the other hand, P-R-E-P, is for people who maybe are in long-term commitments. Maybe they have a partner, maybe they're married, maybe their partner has HIV, maybe their partner has some other risk for HIV. And in those cases, you have to take the medication for months or maybe years. And it's very important to have the initial assessment with a medical provider, hopefully your primary care provider. But let's say you don't want to go to your primary care provider. Go to some regular place for your PrEP treatment. Go to the same place every time, even if it's not your regular primary care provider. In my honest opinion, the best place is your regular primary care provider.
Yeah, because you've built a relationship,
Exactly.
and hopefully that person has much more information about your medical needs ongoing.
But if that's not comfortable for you, just go to the same place all the time for that service, so they get to know you, they get to know what you need to keep yourself as healthy as possible.
And you mentioned, I'm glad you brought in women, because there has been a great deal of discussion about PrEP and women. And I know that on a national scene, we hear a lot more about that. And we're trying to do something in terms of making that a part of the discussion right here in New York City a bit more. And I think also was the CDC's recommendation that not only do they support the validity with respect to PrEP in the doctors, regular doctors, in the doctors, but also the use of condoms.
Condoms are very, very important. And actually, to go back to the blueprint for a moment, that was one important aspect of the preventative strategy. You know, in some places, having many condoms on your person is considered, you know, tantamount to being a prostitute.
Or felony in some instances, right?
And therefore, this is actually a strategy that we're arguing against. We want people to have condoms and to use condoms at every reasonable opportunity. It drives down the risk of transmitting the virus. We want to do that. And if you're using PrEP or PEP, you need to also use a condom. The condom helps you to prevent a sexually transmitted infection. The PrEP does not do that. The
Correct.
PrEP fights the HIV for you, but you also have to fight possibly a sexually transmitted infection.
Okay, now we have all of this knowledge, Terry. Now we have this blueprint. What must we do to make sure it does not just become a dust collector on the bookshelves of health departments, of leaders in the fight to end AIDS, and that the good work that you, all of us, put into as task force members to develop this blueprint, that it's not just another document?
Well, the thing that we're doing, I actually like. What we're doing is a subcommittee of the AIDS Advisory Council has been created, and that subcommittee has representatives of each of the 4 main committees from the task force that the governor initiated to end the epidemic. And that subcommittee of the AIDS Advisory Council is monitoring the implementation. The AIDS Institute has received some funding to initiate some aspects of the work. But what we're also trying to do as individual organizations is to identify how we are contributing in the work that we do every day where we work to end the epidemic. So I think it's that honesty of having a monitoring body that's looking statewide to see that yes, in Elmira, and yes, in Buffalo, and yes, in Albany and Schenectady, as well as in Westchester County or New York City, that we are actually implementing the blueprint. But that group is also asking, what is your organization doing to respond to the blueprint as well?
And I think that's going to be extremely important, almost a report card as such. What are the individual organizations, many who are funded through the AIDS Institute as well as national funding coming from CDC, to be able to say whether it's on the testing side, the linkage side, or the prevention side, specifically what is being done and what are the results. I think transparency and accountability is going to be much more important as we move to bend this curve.
And I think the other thing that is very important and adds to the transparency is really part of the work of the Data Committee, and that is helping us to understand our definitions in the same way. How can you measure your outcome if I'm looking at something one way and you're looking at something another way? So we want to have a common standard across New York State. This is what retention and care means. This is what linkage and care means, and many other such definitions, because that's the way we'll be able to look at what we're doing and say, yes, we've made a difference. We are actually driving down the viral loads of our patients from when we started on ending the epidemic. Yes, we are linking patients to care within 30 days, and this is what we mean when we say linkage to care.
Well, I'm excited because I think for the first time since I've been working directly in the field, the possibilities of seeing this kind of turnaround as a result of the governor announcing this plan last year. And of course, we know that this is the first governor who has taken such a bold step. But that, of course, is not unusual for New York State. I think it was New York State that was the leader in terms of reducing transmission from mother to child, the leader on that, and the leader in terms of establishing an AIDS Institute, and I think that was under this governor's father, Mario Cuomo, right? So that we've been a leader in so many areas as it relates to addressing HIV. So now to have a plan, bending the curve to significantly reduce the number of new infections down to roughly 750 from 3,000 annually by the year 2020, I think it's terribly exciting.
And it fits within the context of what UNAIDS is also doing. You know, this summer I was privileged to be invited by UNAIDS to talk about what we were trying to achieve here in New York State, because there is an international effort in 25 of the largest cities worldwide to also decrease HIV transmission, believing that if we can significantly impact the cities, we can significantly impact the worldwide epidemic.
So you're going to be speaking on that this summer?
I already
Where?
did last summer speak on the efforts that we had begun in New York State. So I'm looking forward, hopefully in the future, to talk about what our progress has been.
Oh, I understand that there's tremendous interest around the world now with respect to what the governor has stepped out to do here, and hopefully that will inspire other cities and other states to do something else.
I think we have to. We've always been a leader. We have always taken care of everybody in New York State. That is one of the proudest things as a citizen of New York City and a resident of New York State that I've ever had, that we don't leave our residents behind. You don't have to speak English. You don't have to be a United States citizen. If you need the care, we will make sure in New York State that you have the care, that you have the supportive services. And I believe, honestly, by 2020, we will lead the way for the United States.
Well, I'm excited, and of course, Sarah, you have given us a wealth of information as it relates to all three of the major points in the governor's plan to end HIV, or I like to say significantly reduce the number of new rates by 2012. We've talked about the importance of getting people tested, getting people linked, and how we move on the prevention front. Now, is there anything you think that the viewing audience should know about this plan that we have not touched upon, or you would like to share, even that HHC is doing, that we might need to know or want to know more about?
Well, I would just add that, you know, one of the things that some of us talked about in the task force is also trying to reach younger and younger people. Most of the focus has been on adults, and that's a right focus. But we also need to make sure that young people, I mean really young people, 10, 11, 12, 13-year-olds, are getting the kind of sound health education that they need to be aware of the risks that they can possibly be exposed to, and making sure that their parents and guardians really understand the value of that. So I'm looking to the future with other people who've worked on the task force from upstate and around the state to do just that, to help make sure that young people are brought into this as well.
And that brings up another point with respect to comprehensive sex education, which we continue to have a battle with right here in New York City. I think New York State is one of the few states where it is mandated in our public schools to have comprehensive sex education curriculum, but that's not happening.
I think it's a challenge because I think it's one of those areas where, in a way, we have stigma.
Still, very much so.
You know, just as we have stigma that we talked about a few minutes ago when we talk about older adults not being sexually active, not using drugs. We have stigma about what young people can or should know. And I think as adults, as people who love and care about young people, I think we have to use good, sound, science-based and medically based health education information for our young people. We need to be the protectors of our young people, and the way we do that is by educating them about the potential risks that they may be putting themselves at, and educating ourselves. Sometimes we feel awkward. Sometimes we don't know. And I'm really glad that at places like HHC and NBLCA, many community organizations, there are sessions for adults, there are sessions for parents, so that they can feel more comfortable. One of the very nice things, I was talking to a pediatrician just last week, and he wanted to be even more informed about PrEP, for example, so that he could talk to parents in a better way, a more comfortable way about what this might mean for their children.
No, I think that those kind of discussions must indeed continue, and we don't see enough of them. Of course, this past Friday, on the national level, they had invited recommendations for updating the national HIV/AIDS strategy. And I think one of the recommendations that went forth had to do with looking at what we're doing in New York State by bringing community people, other professionals from other fields who are just as interested as the one you just mentioned, and we can see some real results by bringing everybody together. This is not something that just one group of professionals need to address. So as I said, I'm very excited about it, and I'm going to thank you for joining me. You've been a wealth of information, and we'll be able to discuss a little bit more as we move forward in terms of making certain that everybody knows about this plan, because I think it's very exciting. And we have lots of work to do, but we're on the road to doing it, and I'm just glad that you were able to join me, Terry, for this event today.
I was delighted.
I'd like to thank Ms. Terry Hamilton for joining me on today's program, where we discuss the governor's plan, intrinsic details of Governor Cuomo's plan to end AIDS by 2020. So for more information on this subject and issues related to HIV/AIDS and other health disparities, please visit NBLCA's website at www.nblca.org or look at us on Facebook and Twitter. The Manhattan Neighborhood Network brings these programs to you to better inform you, the viewer, about the important topics that impact your health and well-being. So please let your family, friends, and neighbors know about this programming. Once again, I'm C. Virginia Fields, and I thank you for joining us and hope you'll tune in next time for NBLCA's Health Action TV here on Manhattan Neighborhood Network.